Without too much further ado, I would like to just hand it off to Dr. Pat Morgan. Some of you may have joined during her initial session with us a few months back, where we talked about CWS and how to navigate their services. Today we're having a happy 4th of July talk, where she will be going over clinical images you might see that are related to various forms of child abuse. Dr. Morgan leads KCAP, which most of you, I believe, are familiar with at this point as well. And I will pass it on to her with now officially too much further ado. And we'll be here to answer any questions or pass along questions in the chat. Thank you, everyone.
Great. Thank you so much, Dr. Luker and Summer, for allowing me to participate in the ECHO session. Can you all hear me okay? Thumbs up from Summer. Okay, great. And so I'm going to share my screen. And thumbs up, everyone can see the screen okay? All right, awesome. So as Dr. Luker mentioned, I will be going over the visual diagnosis of child abuse. And I will say first off that most of the cases will be related to physical abuse or without giving too much information, mimics of abuse as well. As Summer mentioned, I have nothing to disclose. So here are the objectives that hopefully at the end of our time, you will be able to better interpret some of the minor injuries that we might see in infants, understand and differentiate and recognize the high suspicion versus low suspicion parts of the body when we think about physical abuse, and some may call it non-accidental trauma, distinguish between some of the more common mimics of physical abuse, which you may see in your offices, and then be able to explain the initial management and evaluation in cases of suspected physical abuse, including using your local friendly child abuse pediatrician. And so that would be, I'm a child abuse pediatrician, and then my colleague, Dr. Kayal Natarajan, also covers calls. So we are available to help you whenever you have questions. You just can reach us through the operator, and I'll leave my contact information at the end of the talk. And so I thought it would be interesting to use this opportunity to go through our questions and the cases with audience polling system. And so I don't know how many of you have used Mentimeter before, but it's pretty easy. So I'm going to give you all the opportunity now, because I would love everyone to participate, to please either go to menti.com and enter this code, or you can use your phone and scan the QR code. It will bring up this entire presentation, but what it will also do is allow you to participate with the audience polling system as I will be going through some cases. So, and I think we had about, let's see, oh, we now have 21 participants. So I'm expecting to see 20 thumbs up signs. No pressure, but a little bit of pressure. So we're up to 4. So I'll give you about 45 more seconds, and I will put this information in the chat. So if
I think go ahead and put it in there for you, Dr. Morgan.
Perfect. Thank you so much. You're awesome. All right, about 30 more seconds, waiting for some more folks to join.
Guys, join the game. I'm excited. It's like the right thing to keep you engaged during
it's, you know,
during lunch break.
Yes, and it's not a topic that, you know, it's not a warm and fuzzy sort of topic. It's a reality for some of our children, but I've done this before and it has engaged people a little bit more, so I thought it would be interesting. So we're still at 4 people, so hopefully, are people having issues joining?
It took me a second to realize I had to press the thumbs up. So I don't know if anyone else is in that boat.
Oh, okay.
once
we
you've
don't see
scanned it.
names, there's nothing associated. I won't know. We won't be sending your grades, reports, or responses to anyone. We won't know. It's all anonymous.
Hi, Louise. If you're just joining, you can either use the QR code to join or go to www.menti.com and enter that code.
And we'll wait for about 15 more seconds. So as we're waiting those 15 more seconds, just would like to tell you that with the cases, the patients are all healthy unless specified otherwise, that if they have a significant past medical history, I will give that in the vignette. The only thing besides an initial brief scenario will be their social history and any pertinent positives or negatives on their physical exam. And so with that, I'm going to go ahead and move to the next slide. Okay, so for our first case, this is a 6-month-old full-term infant, previously healthy, was brought into clinic for a cough, URI symptoms, and vomiting for the past 3 days. There's no report of fever, there's no diarrhea, and no rash. And there are some ill contacts at home who have similar symptoms. Social history, the patient lives with her mother, who's in her early 20s, and there's a 2.5-year-old brother. Father of the infant is not involved. On exams, little one is afebrile, has an occasional wet cough during your exam. And you notice on the eye, there's what appears to be a subconjunctival hemorrhage, the right eye. Lungs are clear, skin, there are no findings of bruising, pattern marks, or rash. So the finding in this infant is most likely caused by A, cough, B, vomiting, C, bleeding disorder, D, trauma. In the next slide, you'll be able to vote. The finding in this infant is most consistent with which one of these? Five more seconds. Okay, so 4 of you got it correct. The answer is trauma. So a subconjunctival hemorrhage is caused by capillaries in the conjunctiva. And in infants and in little ones, the most likely cause is due to direct trauma, whether that's a hit to the head, a slap to the face. It is uncommon for infants to really be able to generate enough pressure to cause a subconjunctival hemorrhage unless we've seen cases where they have severe cough with pertussis. Here is also a list of other causes of subconjunctival hemorrhages. Of course, we can see it due to birth trauma, but these usually resolve after a few weeks. We can also see it in hypertension, Valsalva, strangulation, suffocation, or coagulopathy. As I mentioned, coughing as a cause, we can see that in adults. We can see it in older children and teenagers, and it has been seen in some infants again with severe cough with pertussis. And in cases of suffocation and strangulation that's due to abuse, we might also see petechiae or around the eye as well. It is important anytime we have any concerns for bleeding, such as in a subconjunctival hemorrhage, that we try to get a bleeding history as well. So we ask about birth history, any prolonged bleeding, cord bleeding, is there a family history of any bleeding disorders, what's the mother's menstrual history, if they are male, what was the bleeding like surrounding circumcision if they are circed, and then any other bruising history. And then I'm not going to go into all of the evaluations for coagulopathies, but minimum screening would include a urinalysis, a PT-PTT. We also get a fibrinogen, and then looking at stool for occult blood. So the answer again is trauma. So if you see trauma in a little one, it is very suspicious and concerning for physical abuse. So let's move on to our second case. So this is a 3-month-old 36-week preterm female. She's in for her 2-month well visit. And during the visit, you notice what looks to be a bruise. It's an area on her cheek. The mother isn't sure of what happened, but says that her 9-year-old son is often rough with the baby. Social history, patient lives with her parents and 9 and 10-year-old brothers. Mom and maternal grandmother are the primary daytime caregivers, and the patient does co-sleep with mom. On exam, she's well developed. She's not in any acute distress. Her skin is only remarkable for the area as noticed here, which is about 2 centimeters on the left cheek, and the extremities appear normal. So you think that the area is a bruise. Which of the following actions are recommended for this little one? A, see the patient back in 1 week to make sure the bruise resolves. B, no imaging studies as the infant has a normal neurologic exam and you've palpated the long bones and that's normal. C, investigate the cause of the bruise further and report the injury to CWS. D, if there's no family history of bleeding disorders, then no laboratory tests are needed. So here's the slide with the polling. Here are your choices. What is your next step of action? It says proceed to, okay. That should open the voting. Okay. See the patient back in 1 week. No imaging studies since the long bones are normal. Investigate the cause of the bruise, CWS referral. No family history of bleeding disorder, so we don't need to obtain any labs. Five more seconds. Oh, I think everyone's voted. Okay, so with bruising, the correct answer for this case is investigate the cause of the bruise, which is highly suspicious for inflicted trauma or physical abuse in the absence of any history. So the mom, again, she only reported that maybe the 9-year-old brother did something, but without a clear explanation, this would be very concerning for abuse. And since this is a non-mobile infant, that is even more suspicious. So again, we would do the things, ask about bleeding disorder history, because we want to make sure that we have all the things on our differential. And I have had patients who've presented with bruising that is suspicious that ended up having a bleeding disorder. But I would like to just say that a bleeding disorder and a highly suspicious skin finding, they're not mutually exclusive. You can have a child who's being physically abused who also has a bleeding disorder. So the initial management in this little one would include neuroimaging. So CT head, quick, fast, it's without contrast. If they're neurologically stable, you could consider an MRI brain, but then you have to think about sedation. And so there's a little bit more that goes with that. I've mentioned the coag workup, PT, PTT. We also do a fibrinogen. You're going to get a complete metabolic panel, which we're looking for occult trauma, such as liver injury, pancreatic injury. We're adding a lipase, serum transaminases, and then urinalysis. Now I put plus or minus dilated eye exam, but if there's facial trauma and they're under 6 months of age, you're going to get an ophthalmology consult, irregardless if their CT is negative or not. And then I'm always putting in a plug. You can always call us if these kids are in your office and you have a question. You can always call us so that we can help discuss and decide what's the best management. And so this is important. This would be an infant that you would send to the emergency department to go ahead and have that physical abuse evaluation obtained versus trying to do all of the pieces one at a time in an outpatient setting, because most importantly, we want to make sure that if this is an infant who's being abused, that we make sure that they're safe. All right. So we're going to move on to our third case. This is a 4-month-old full-term healthy female, again, in your office for concerns for a possible ear infection. Patient has been fussy with a possible low-grade fever. Patient is being cared for by a family member, and this is a family arrangement. You don't have any other further details, but CWS is not involved. The patient is afebrile, fussy but consolable, and you notice, and I apologize for the not so great quality of this image. I tried and tried and tried, but the area at the upper gum next to the speculum there is noted on your exam. Also of note, the right TM is bulging and erythematous. So based on the finding, you should A, do nothing. This is a normal finding. B, ask about any facial trauma and refer the patient to the ED for a physical abuse workup. C, discuss proper feeding technique and see the patient back in 1 month. D, refer the infant to a dentist. And here are your choices. Do nothing, ask about facial trauma and physical abuse workup, discuss proper feeding techniques, refer to your dentist, to a dentist.
An unusually unanimous vote
I
here.
know.
Oh,
You spoke too soon, Dr. Luker. All right.
I'm also the kind of person that loves having a little outlier here or there. Things interesting.
Okay, so I've been forgetting to do this on the other slide. So this actually, this will show you the correct answer. So asking about facial trauma and pursuing a physical abuse workup. So let's talk a little bit about this finding. So this is a torn frenulum. This is not the same picture, but this was a better picture, but I felt it was almost a little too obvious if I showed it. So that's why I used the other case. But the number one cause, so there are 3 frenulum. There is the upper frenulum between the gum and the upper lip, the lower frenulum, and then there's a lingual frenulum, which is under the tongue. And the number one cause to an injured frenulum, whether it's torn or there's a bruise, is trauma. And we know that kids who are first learning how to walk, sometimes they pitch forward, that head goes forward and boom, they get an injury to their mouth. So we can see that. But again, if this is an infant who's not really doing much, it is unusual to see this type of injury. And so what I will typically do when I'm called in for a consultation is I'll say, I'm looking in the mouth to see if there are any teeth or any oral lesions, but I'm also looking very closely at the upper, lower, and lingual frenulum. So what you may sometimes see also with these frenulum is that it may look, either it can be torn, but it might have an injury where you see just the hematoma, so just a blood collection. It might look like a bruise, and then that can look like something else. I had a patient not too long ago who had a lingual frenulum that looked like a hemangioma, but it actually was a hematoma and it was due to trauma. The bottle was forced into the baby's mouth, and it also can heal and look like a whitish area. So all of those are things to keep in mind as you're evaluating things in that area. They usually will resolve on their own unless they're very large or if the alveolar bone is exposed. And ways that this happens in an inflicted manner is punch to the face, slap to the mouth, force feeding. Those are the most common ways. And if you remember in this case, this baby was also, there was a concern for an ear infection. So this baby was fussy, crying. And so crying is the number one trigger for physical abuse for infants and many young children. So just keeping all of that in mind. So you all are doing a great job thinking through these cases, and you'll see some repetition in these 3 cases, because the next thing I want to talk about are sentinel injuries and why this is important. And I'll show you some cases at the end where sentinel injuries were missed and unfortunately did not have good outcomes for the children. So Dr. Sheets, she's a child abuse pediatrician, and now 10 years plus ago, she started doing some work on sentinel injuries and seeing that these injuries, which are described as visible, minor or small, poorly explained injuries that are in young infants that raise a concern for abuse. They have no other really good plausible explanation. But these injuries were showing up in kids who came in more severely injured or dead. When they went back and looked through medical records, there was documentation by medical providers of injuries that were sort of the precursor to worsening physical abuse. And so these injuries are suspicious, again, because the infants don't cruise, they're not really mobile, or they don't have a plausible explanation. These are the top 3 sentinel injuries, and we went through these in the cases that I just presented. Bruising, intraoral injuries, specifically, we've talked about the torn frenulum, but other intraoral injuries, such as injury to the palate, especially again in kids that are not moving. And then subconjunctival hemorrhages, which we talked about in case number 1. So I'd like to tell you about a bruising clinical decision rule that you can use in your offices if you have a little one that presents with bruising or skin findings that are raising a suspicion for abuse. So it's called 10-4 FACES P. And so this is helpful to use in children who are under the age of 4. It's based on work that was done by an ED physician who does a lot of work in child abuse and biomechanics and things of that nature. And initially, when she started doing this work, looking at children and bruising patterns that were highly concerning for abuse, she came up with 10-4. She expanded her studies and her research to come up with this expanded bruising clinical decision rule. So the 10 is for the body parts torso, so that's the front and back of your chest and back. E is for ears. The N is for neck, and although it's pointing to the back portion of the neck, I really say anything on the neck is suspicious for inflicted trauma. And then the faces portion is the frenulum, which we've talked about. The A is the angle of the jaw, so this portion of your jaw. The cheeks, the fleshy portion. The E is for eyelids, and the S is for subconjunctiva. The 4 is for 4 months and younger, and I also like to say it's also, we're using this tool for kids that are less than 4. But in infants who are 4 months and younger, that whole baby is high suspicion. So if they have any bruise anywhere, that is highly suspicious for physical abuse. And I've had conversations with colleagues because it's a small bruise, and maybe the patient that I showed you where it's just a small area on the cheek, and then you're sending the patient to go to the emergency department to do this whole big workup. I can tell you in the years that I've been doing this, it has been surprising the amount of occult trauma that we find with skeletal surveys and neuroimaging in kids who only presented with a small bruise, a small facial bruise or what have you. And then the P is for pattern injuries or pattern bruising. So it can look like a slap, a grab, or loop marks. And I'll show you some examples. So in this little one, I like to show this because it's a good reminder of non-abusive injuries that can be very concerning. So this is a 3-year-old who has these darker areas under his eyes. It looks like he has black eyes. Basically, anytime you have a child who presents with what appears to be black eyes, but no other trauma to the eyes, always check their forehead. So you can have a forehead hematoma or a contusion, which this part of the body is a low suspicion part of the body. We talk about the facial T, which is the forehead, the bridge of the nose, and the chin. Those are less suspicious injuries depending on the age of the child. So this toddler did have a forehead hematoma, and as that is resolving, the blood tracks down here to the lower, this looser tissue under the eyes, and it starts to look like black eyes. This is a little one that has injuries to the neck, and again, that is highly suspicious and concerning, and this would warrant physical abuse evaluation. And I will just use this opportunity to say that physical abuse evaluation, we do the whole thing. I like to say it's the whole kit and caboodle. You're not going to pick and choose and just do labs or just do a skeletal survey. You're going to do all of the things that are involved with that. And this picture, I like to use it because also it reminds us of how we need to document if you are taking pictures, that you want to document the injury or the finding from further away, and then a closer one, and then one with a measuring device, whether that's an L ruler. If you don't have an L ruler, you can use a coin, something that's a standard size. And then here, this is a 6-month-old who presented for and was diagnosed with abusive head trauma and ended up having bruising on both of her ears. And then this one is not a great picture, but I had a case a few years back where a baby presented with scalp swelling and there was concern for an underlying skull fracture. But when I examined the baby, and this is not the baby, but this is a picture of the finding, the swelling did not feel like other scalp swelling might appear, might feel like. And so it didn't it crossed suture lines. It felt very liquidy, and there was no history of trauma. And so I was being called in for possible physical abuse evaluation. We imaged the area, and it turns out that it was what's known as delayed subaponeurotic fluid. And I don't know if any of you have had it. It's not really common, but it's something to kind of keep in the back of your mind. When someone presents with delayed scalp swelling, these patients are usually about a month to 4 months of age. There's no report of trauma, but it feels very different than any other type of scalp swelling. So I just think that that's an interesting sort of zebra that you could potentially see. I'm going to move on to case number 4. So this is a 4-month-old full-term infant brought to daycare after being homesick the previous week. The daycare worker is concerned for burns and calls CWS. The mom is in her early 20s. There's a 2.5-year-old son who also attends the daycare. The father of the infant is not involved, and the mother lives with her own mother. So it's a mother, maternal grandmother, and the 2 children. On physical exam, there are multiple areas that are reddened, peeling skin in the diaper area, and then this area that's at the right lower leg and the top of the left foot. So the findings in this infant are most consistent with A, healing burns, B, impetigo, C, diaper rash, D, ringworm. And here are the polling questions. Finding in this infant most consistent with healing burns, impetigo, diaper rash, ringworm. Five more seconds. Oh, that's all 10. Okay.
I'm not jinxing it this time.
But it's all 10. So, very interesting. The answer is impetigo. And I like to bring up impetigo and burns because impetigo, we probably see it in our office, your office, more commonly than not. But because it's a physical abuse talk, you sort of got swayed into thinking that it was possibly a burn. But impetigo does mimic burns. Things to think about, well, first of all, knowing that it's caused by staph aureus and strep. It can develop where there's a rash or a sore. It's contagious. And then you have the non-bullous and the bullous type, usually treated with either topical or oral antibiotics. And how this gets confusing is that I'm going to go back to let's see if I can go back. Okay, so with impetigo, once you have bulli that are large and they start to rupture, it can start to look like a burn because you have these areas of healing skin around these areas of redness. This is actually crusting that you can see with impetigo versus it does look like an eschar, could look like an eschar. But again, this is a pretty common mimic of physical abuse or a burn. And so here, just to show you a burn, this is a superficial partial thickness burn. So we don't use 1st degree, 2nd degree anymore. We talk about either superficial thickness, partial thickness, which can be superficial, or full, a deeper thickness, and then full thickness. But once the burn blisters or ruptures, it can look pretty similar to the pictures that we just saw with this infant. The other thing, when I'm thinking about a case and trying to decide whether or not my suspicion and level of abuse, I also try to think how it could happen in an abusive manner. And I think that that has helped me in some cases. So whether I think about it the other way, if it's a non-inflicted or non-abusive manner, how it could have happened. I also think about it on the other side as well. So a presentation like the one that I just showed you could happen in a patient where there's an immersion burn, but it would look very different. It could also be, we've had instances where infants were being bathed in a sink and the water that came out was very hot. It could look similarly to that as well. But there are things about burns that are a little bit different than what that looked like. So you may see splash, droplets. You may see lines of demarcation when it's an abusive inflicted burn, such as immersion. It's usually symmetric. So those are things to keep in mind as you're thinking about, is this impetigo or is it a burn? And there, it's not always easy. And again, we are here to help you think through cases. If you err on the side of being more cautious and sending them to the ED, that's probably the best thing to do. But it's just to keep this on your differential that burns can look like impetigo and impetigo can look like burns. So just to show some more examples of burns, these are cigarette burns. And one thing to know with cigarette burns is they are pretty well circumscribed if they are abusive. If they are non-abusive, such as a parent is holding the cigarette down, maybe at waist height, and the child runs by, it's more of a glancing type of burn. So it looks very different than what we're seeing here in this picture. The other thing is the diameter of most cigarette burns tends to be about 1 centimeter. And you usually see this deeper eschar that's here and then surrounding erythema. This is a little one who also has, this is a cigarette burn as well. You sort of see this punched out appearance, and this infant was being evaluated for failure to thrive. Most physical abuse talks talk about this type of burn, which is, it almost looks like a smiley face, but this is a cigarette lighter burn. I've only seen a handful in the years that I've been doing it, but this is a pattern that you should just familiarize yourself with. This is a non-abusive iron burn. A 9-year-old who was running fell onto a table where a hot iron was still there. And so you see the outline of the iron here. And important things when you have a verbal child is really trying to get that child alone and asking in a very open-ended manner, can you tell me what happened to your face, versus were you burned by an iron, and allowing the child to just give yes or no answers. If you're getting a medical history from a child alone, you really only want to ask questions that are as open-ended as possible so that the child can tell you, versus getting a bunch of yes or no's. And if you do have to ask a question that gives a yes or no response, the goal is to always try to get back to a more open-ended type of narrative. So for example, if the child gives you a yes response, you can say, can you tell me what happened? Can you tell me what happened? And so that would be a way to get back to your narrative, even after they give you a yes or no. This case here, I've seen a couple of times. This is the child walking by a stove or a table, reaches up for that cup of tea or noodles, looks up, brings that hot liquid down to their face. You see the most intense portion of the burn where they first make contact, and then as the liquid cools, and if they're wearing clothing, you'll see that the burn becomes less in severity. And so that could be a plausible history. If it's a verbal child, you obviously we would want to talk to that child alone and make sure that we get an appropriate history. This looked to be an accidental burn, but when the providers actually spoke to the child's face was held up and the stepfather poured a hot liquid on the child's face. I have had one case in 24 years of this slide below. This is an example of what looks to be a burn, but it is dermatitis caused by X-lax. This was a little one who got into X-lax, and if you can remember, the X-lax looks like chocolate, and started to have very profuse diarrhea. But if you'll see, the area of redness is right in the pattern or outline of where the diapered area is. And so with X-lax dermatitis, you can see just mild redness, but you can see bullae, which then rupture and look very concerning for a burn. Okay. Other mimics of burns have had a handful of these cases. Phytophotodermatitis, they love to ask about this on child abuse boards. But basically, it's when you see something that could look like a burn and you get a history of perhaps they had a beach party or a pool party and people were making drinks, margaritas. Sometimes this is called a margarita burn. And the sorolins that are in the lemon, the lime, mangoes, figs, they're in certain things. And when that gets onto the skin and they're exposed to sunlight, it can produce a burn. The burn can be mild, like this, where you just see maybe some darkening, hyperpigmentation, or some redness. It can look like handprints. It can have other things that look like burns as well. And it can actually be as bad as this, where we see blistering associated with it. So something to just keep in mind when you see a child who has something that looks like a burn, asking about any recent activities where there might have been sun exposure, along with this combination of sorolins in the lemon, lime, figs, celeries. There are a bunch of things that can cause this. All right, case number 5. So this is a 5-day-old full-term female brought into your office for her first visit since her discharge from the newborn nursery. Her mom said that she's feeding well, that she is exclusively breastfeeding, and she's eliminating appropriately, no real problems. Mom is 38, single, no other children, no concerns in the household, no prior CWS. On exam, you notice this bluish, non-tender area, those areas on the abdomen. So you ask the mom how long the area has looked like that, how long it's been there. And she said she noticed it when the baby got home. The baby came home at 2 days of age, and it's been becoming darker since the baby has been home. So the findings in this infant are most likely A, congenital dermal melanocytosis, B, slate gray macules, C, dermal contagiosum, D, bruises. So the findings in this infant are most likely due to Five more seconds. So the answer is congenital dermal melanocytosis, and that is a mouthful, but that is the name for what we used to refer or call them Mongolian spots. So we're not using that terminology anymore. They're referred to as dermal melanocytosis or congenital dermal melanocytosis. They're also called slate gray nevus, so not slate gray macules. Just trying to trick you a little bit with that, NEVUS. And what they are basically birthmarks. They are trapped hyperpigmentation in the melanocytes, and we see them in people of color. They can be bluish, grayish. They're not tender, they're flat. And they're typically seen on the back or buttocks, but they can be anywhere. And so what I like to remind folks is that if they are anywhere outside of what we consider to be the normal places like the back, the buttocks, to really document them. If they're excessive, such as this one, if they have a lot. I had a patient who had them all over her back, and I had another patient who they call CWS from daycare because they thought it was bruising. And when I contacted the PCP, they had just moved the PCP from a different state, sent over the records, and was well documented that it was dermal melanocytosis. It can differ in size, and it's usually present at birth or a few weeks later, and it'll get darker and darker. And it could disappear in childhood, usually about the time that they're about 6 or 7, but it could persist into adulthood as well. So just a reminder that things that look like bruises, if you had a concern that this was a bruise, what would you do, right? So things to think about. What do bruises look like? They're usually also associated with swelling or tenderness. The location, how long has it been there? Those are things that you want to make sure that you're asking questions about. And if you are concerned that it's a bruise and they are a little one, then you would need to pursue physical abuse workup and evaluation. And if you have questions about any of it, again, we are here to help as child abuse pediatricians. Here are some other skin findings that are worth mentioning. This is a classic, this is a bite mark. And you can see very interestingly in this patient, you can actually see the teeth. And with bite marks, we usually don't see the whole thing, but if we see a portion and we can measure what's called the intercanine distance. So remember, your canines are the upper portion. And if we measure that area and it's greater than 2.5 centimeters, then it's usually not a child. So one of the cases that I had a toddler who was brought in for 23 bite marks. They were super infected, so came in for IV antibiotics, and they called me because he had 23 bite marks. And the mom said that the 3-year-old brother bit the child. They were fighting over a toy, and we had a forensic odontologist who came in, and because I just measured 4 of them and they were greater than 2.5, so I knew it wasn't the child. And the forensic odontologist did the impressions on the 4 adults in the house, the mom, the maternal grandmother, a maternal aunt, and a maternal uncle. And then did this overlay, like very CSI kind of overlay of all the impressions on several of the bites. And it turned out it was the mom. And the mom, the number one reason I've heard for adults biting kids is that the child bit her. So the child bit her and she admitted that she just lost it and she just kept biting the child. So that's just one thing about remembering the intercanine distance. And then here is dermal melanocytosis, just on the leg. Could look like a bruise, but it was flat, same color, had been documented in the electronic health record previously. And so was felt that this was consistent with that. And then this is pattern injury. So this slide, normally I take this portion out. This is a racetrack. This was a child, an infant who had been crying a lot because had URI symptoms and was hit multiple times with this racetrack. And so these linear marks here are from being hit. So this is a pattern injury. So if you're looking at high suspicion parts of the body, and pretty much anything on the back of the body is considered high suspicion. Think about kids running and playing. They're not usually having injuries to their backs. Not impossible, but it is a high suspicion part of the body. Other high suspicion parts of the body, as I mentioned, remember your 10-4 face is P, but you have the sides of the face, the neck, upper arms, the thighs, and bony prominences like your chin, your shins, your elbows. Those are considered lower suspicion parts of the body. So here we have a little one. This is the side of the face. This is a patterned injury. This is a slap mark. And what you typically see with slap marks is you see these areas, these linear areas, either of erythema or sometimes with petechiae, but you don't usually see fingerprints or finger outlines. But this is classically what you'll see. So this is a patterned injury on the side of the face, most consistent with a slap. And this is another patterned injury. This is what we call a curvy linear pattern mark. And so you'll see the curved portion here, the linear portions here. And that is most consistent with a loop. And we have been seeing a lot of loop marks with the charging cords for phones because they're handy, they're accessible. People are charging their phones. They take the phone charging cable and they use it to hit the child. So some pattern injuries, your bite mark, and then another example of dermal melanocytosis. Mimics of bruises, just some things to think about. Bleeding disorders, vitamin K deficiency, aspirin ingestion. This is an infantile hemangioma that can look like a bruise. So again, just medical history, your exam documenting, assessing for safety, all of those things would be important. So let's move on to case 6. This is a 14-month-old who actually is presenting to the ED for refusal to bear weight on his left leg that was noticed on the day of presentation. The parents deny any trauma, but report that his 4-year-old brother pays roughly with him. And I bring this up again as a part of the history because it's not an uncommon history that we will sometimes get with when children present with injuries or findings. There is no history of other injuries, and his past medical history is unremarkable. There's no fever or URI symptoms reported. Social history, no prior DSS. There's a 6-year-old sister. Mom reports DV with her ex-husband, and there's no contact with him at the time, and he is the father to both children. On exam, there's mild tenderness on the left lower extremity. He will not bear weight. And this is his X-ray finding. And there is a positive arrow sign. So that is the area of concern. So the question, the finding in this child is most consistent with A, toddler's fracture, B, osteogenesis imperfecta, C, rickets, D, physical abuse. I'll let you look at the image one more for a moment. And here are the polling questions. Five more seconds. Okay. So this is a toddler's fracture. And so this, I will tell you, I presented a case like this to some child abuse colleagues, and it was very interesting what the thoughts were about a physical abuse workup. So let's talk about this fracture type. So it's also known as child accidental spiral tibial fracture. And it is spiral or sometimes oblique in nature, usually on the distal portion of the tibia, and it's usually in children that are learning to walk. And so if you think about it, a child who's learning to walk or an infant that's learning to walk, how many times do they fall? A gazillion times. And so what happens is the parents don't really attribute any type of fracture to that because they fall so many times. But what you need in terms of history and the mechanism of injury is that the foot is planted, there's a twisting or rotation of their lower extremity, and they land and fall, causing the spiral or oblique fracture. So it is pretty common in kids who are learning to walk, can also occur with routine play. And again, the parents will not really report significant trauma. So you'll have this unexplained fracture, but this is a known entity. And so the question becomes, it's a known entity, but it's an unexplained injury. Do you get a physical abuse workup or not? And I will tell you, when I asked this question to child abuse pediatricians in a presentation that I did, the room was split. There were those who said, no, this is a known entity. We don't need to do any further workup if there aren't any other concerns. There are no skin findings. There are no social red flags. And then there were those who said, well, it's still an unexplained injury and we should still pursue the workup. So these would be cases where I would warrant, I would say we could have a discussion and determine whether or not we err on the side of being very cautious and follow all of the physical abuse evaluation guidelines. So if you do have a child under the age of 2, where there's a suspicious injury or suspicious symptom, or they have burns, you would want to get a skeletal survey. So this is not a skeletal survey. This is what people might refer to as a babygram. And with this babygram, we're not getting the individual images as you see here, which include obliques of the chest. So this is recommended, as I mentioned, in kids who are under the age of 2. We also recommend, if there's a suspicion for abuse, to get a follow-up in 2 weeks to increase the diagnostic yield for concerns of abuse. Although any fracture type can be seen with physical abuse, these are the ones that are highly specific for physical abuse: your metaphyseal or corner fractures, posterior rib, and the 3 S's: scapula, spinous process, and sternum. Now, these other fracture types, low or moderate specificity, can be seen in physical abuse if you don't have an appropriate history, appropriate development, or age of the child. So here are examples of posterior rib fractures. These are healing. This is what we call callus formation. And so you'll see those here. This is an example of a sad case where a little one was brought in for URI symptoms. They did a chest x-ray, the lungs looked okay, but no one commented on this bulbous area here, which was a healing fracture. And this baby came back in 5 days later, deceased due to fatal abusive head trauma. And then this is a buccal fracture. So this is a non-abusive fracture. It's due to compression loading that you can see with a fall on the outstretched hand, or with compression loading on the foot causing this buccal fracture. So not necessarily seen with abuse, what these are. This list, I can't go into all of these things, but these are mimics of skeletal injury. You might recognize the blue sclera that you might see in OI. With osteogenesis imperfecta, by the time they're starting to fracture, we do see that their bones start to look a little bit more demineralized or poorly mineralized. This is, these are rachitic rosary that you can see in rickets. And then again, other things that you can see that can look like inflicted or abusive skeletal injury. So our last case, this is a 4-year-old boy who presents to the ED for URI symptoms and vomiting. When he's undressed, the area on his back was noticed. Social history, there's no prior CWS, Department of Social Services involvement. There's a 6-year-old sister. Oh, this is the same history. So that's not right. Multiple linear areas of erythema across the back, about 5 centimeters in length, and the skin is intact, no other areas noted on the body. And there was no social concerns with this family. So the finding in this child is most consistent with A, abrasions, B, bruising, C, cupping, D, coining. Abrasions, bruises, cupping, or coining. I'm leaving the image up just a little bit longer. What do you think those findings are due to? Five more seconds. So this is coining. And if you haven't seen this yet, and I've had maybe one case in all these years, it is a cultural practice that's done for healing, where they warm the skin with oil or some type of balm, and then they take a coin and rub it along the body. So it's to help, for instance, in a child who's having coughing or vomiting, it's helping to get rid of those symptoms according to that cultural belief. It is seen commonly practiced some parts of Southeast Asia, Southern China, and per report from verbal children, it's moderate to no discomfort. These areas of petechiae do actually resolve within weeks. It is often considered non-abusive, but if there's significant harm to the child, then you could consider a threat of harm or risk of harm. Now, very honestly, I do not know how it is handled here in our state, because we do have a separate threat of harm or risk of harm in terms of cultural practices. So I think that's something more that I'll have to learn about and have more discussion with our CWS colleagues. Here are examples of cupping with celebrities. It's become pretty popular, but when we involve children, and again, harm and discomfort, is it abuse? Is it non-abuse? If it's a cultural practice and it's done for healing. So these are examples of cupping, where the cup is placed on the skin, it's heated, and then there's a vacuum that's formed, it stays on for a while, and it's to help release infirmities. This is examples of moxibustion, which can look like burns, which they are actually burns, where an herb is placed on areas of discomfort, again, for healing. Usually where there are acupuncture sites, they'll put this herb on as well, and it can resemble, no, it is a burn, not can resemble, it is a burn. One other cultural practice, this is caída de mollera, and it's basically when an infant has a depressed fontanelle, which you might see in dehydration. It's also thought if a baby is being breastfed and pulled too quickly off the breast, that this can happen. And one of the remedies that they do is they'll hold the baby upside down and sort of shake the baby to kind of release the fontanelle, to get it to become normal and not sunken. And so we can see this in some of our Latin American and Mexican families. So I would love for you to, I'm going to try to get to the questions. I know that I only have 3 minutes left, but some take home messages. Just remember, The skin is most frequently traumatized in organ system, so we might see things like bruising. Remember, your 10-4 faces P. The physical abuse workup is a whole thing where we do neuroimaging, skeletal survey, and labs, not just picking and choosing, and then dilated eye exam in certain patients. There are mimics of abuse that can look like abuse, but have a low threshold to adding physical abuse to your differential diagnosis. And know that Dr. Natarajan and I are always available to discuss cases with you. Here are my references. This is my phone number. You will have access to a handout for this presentation. And I will try to answer questions and go over the post-test. Summer, is there anything else I should do?
Nope, I can go ahead and run the poll while you do questions, maybe?
Okay.
Is that okay?
Yeah, the questions from the chat.
From the post.
Oh, the post questions? Oh, okay.
Or you can do the chat questions as well. I think there's one.
I think
There's
there's
what?
one, yeah, while we're doing the post questions.
Okay. What is the one
Let me get
question?
started. It's right at the bottom. And it's a very good question, actually. So what does a bruise look like if it's on top of, I can't pronounce the words yet either, unfortunately.
Yeah, so that is a great question. So think about, any other bruise. If it wasn't overlying an area where there's a slate gray patch, you're going to, the coloring usually isn't so homogeneous as you might see with dermal melanocytosis. So it's going to look a little different. We used to date bruises based on the color. We don't do that anymore. But as a bruise is resolving, it does have qualities where it can look a little bit more reddish versus yellowish versus greenish. That still does exist. We just don't attribute a timing to that color. Coloration anymore. Tenderness, swelling, all of those things, remembering that your slate gray patch is going to be flat, non-tender, not associated with swelling. So those are ways to help you differentiate, is this an acute bruise on top of an area that's a slate gray patch? So I hope that answered your question. If not, reach out to me. And we are at time, so I want to go through the answers very quickly. Let's see. Okay. So number one, fractures are the most common injury in child physical abuse. That's false. Bruises are the most common physical injury. All of the following are considered high suspicion parts of the body, except shins. Remember, 10-4 faces P. Number of images in a correctly done skeletal survey. Oops, I don't think I actually gave you that answer, but it's 21. I didn't expect you to count that really fast, but it's 21. So apologies for that. The role of the pediatrician in suspected cases of child abuse are all of the above. If you have a suspicion, that is our threshold. If you remember from the CWS referrals, to calling CWS is just a suspicion. You don't have to prove anything. You just have to think it. And then remembering that if a child presents with an injury, to add physical abuse to your differential. Remember, sentinel injuries are key in helping prevent a child from coming in, or an infant more severely injured. And there are ways in your office. I know there's a lot to do in your office visits, but you can talk about child maltreatment prevention, especially during high trigger times like crying, during illness, toilet training. Those are high trigger times for inflicted injury. So thank you for your attention. You have my contact information. Reach me if there are any other questions. And thank you, Dr. Luker and Summer.
Thank you so much. That was a very excellent, very high yield talk. I think we all got a lot of learning out of it. So thank you so much, Dr. Morgan. We're very happy to have you back. Thank you for keeping us awake and engaged. That was excellent. I'm absolutely stealing your idea for the future. I love this. Thank you so much. Thank you everyone for joining us.
All right, thank you.
We will see you back in 2 weeks. And Summer, help me out. You're always so fast and on it.
Dr. Rachel.
Oh, yes.
Pediatric diagnosis to know. Yeah.
Perfect. Exactly. So we'll have a sports medicine theme for the height of summer when everyone is out and active. Perfect. On that note, enjoy the rest of your day. Thank you everyone again for joining us. Thank you so much, Dr. Morgan.
Thank
We'll
you.
see you all next time. Thank
All right,
you.
bye-bye.